First of all, I would like to thank the organizing committee in the ISN for inviting me to present this talk concerning focal segmental glomerulosclerosis. This is my agenda. By definition, glomerulonephritis are a group of diseases affecting the glomerulus characterized by inflammation of the glomerular structures due to immune disruption. And it leads to renal interstitial tissue damage. It represents 2 to 7% of the internal patients. Clinically, glomerulonephritis can present by 5 syndromes, either acute nephritis, characterized by oliguria, non-nephrotic proteinuria, hypertension, microhematuria, nephrotic syndrome with proteinuria, with heavy proteinuria, low albumin, edema, and high lipids, rapidly progressive glomerulonephritis with renal dysfunction, non-nephrotic proteinuria, usually normotensive, but there is microhematuria and CAS. The fourth clinical presentation is chronic GN, with which is characterized by slow progressing renal dysfunction, hypertension, anemia, and hyperparathyroidism, and the patient may be asymptomatic. Etiologically, if the cause is not identified, so this is primary FSGS, this is primary glomerulonephritis. But if it is identified well, this is secondary glomerulonephritis. And this is applicable even for the different types of glomerulonephritis. So the secondary cause could be genetic, like Alport syndrome and Fabry, or infections and other causes. Infection-related GN, especially viral infections and bacterial and viral infections. Tumors like lymphoma, autoimmune disease, as what happened in lupus and vasculitis and GPM disease. Or it may be a manifestation of systemic disease like diabetes. Pathophysiologically, glomerulonephritis could be due to circulating immune complexes which will be deposited or in situ formed in the glomerular basement membrane. Also, this is or due to antibodies against the GBM itself, or the inflammatory cell infiltration affecting the glomerulus with release of proteolytic enzymes, oxygen-free radicals, and tissue injury, and increasing glomerular permeability. Also, complement activation has a major role in some glomerulonephritis, with platelet activation, thrombosis, and further glomerular damage. Mesangial cell proliferation and mesangial matrix deposition, and finally fibrosis. Of course, ischemia, toxic insult, or infection play an important role in the glomerular barrier damage. Pathologically, or pathological diagnosis should include the primary diagnosis of the disease itself, including also the pattern of injury, the score and the class or grade of the disease, like what is detected in lupus nephritis, IgA nephropathy. Additional findings like ATN or interstitial nephritis and so on. Ancillary studies show also the type of the IgG subtype, the pronase antigen retrieval, and so on. Also the grade or chronicity score, based on which we can manage the patients accordingly by the immunosuppressive or other medications. Back to our disease, which is focal segmental glomerulosclerosis. It is characterized by sclerosis of segment of the glomerulus, but not all the glomeruli. So sclerosis of segments of some glomeruli. The FSGS can occur at any age, but it represents 20 to 30% of adults with nephrotic syndrome, but in children it is less common than adults. It is more common in males, and the commonest cause of primary GN in adults. And in cases of steroid-resistant FSGS, it carries a high risk to progress to end-stage kidney disease. And the second line of treatment usually is ineffective, with a recurrence rate of 20 to 30% after renal transplantation. The etiology of FSGS is related mainly to the podocyte. This podocyte injury of the podocytes, which could be due to genetic predisposition, permeability factor injury, viruses, drugs, or adaptation. So genetic predisposition due to mutation of many genes encoding proteins of the different structures of the podocyte, especially slit diaphragm, cell membrane, cytoskeleton, nuclear protein, mitochondrial. All of these proteins, if there is disturbance in its structure, result in loss of integrity of glomerular filtration barrier, resulting in FSGS. Circulating permeability factor, it is a factor which is not, it is unknown factor, and its presence result in increased permeability and the food process effacement and proteinuria. Viral infections, especially HIV, parvovirus, CMV, Epstein-Barr virus, hepatitis C, and currently the COVID-19 can present with FSGS and can cause FSGS. Drugs and agents like heroin, interferon, lithium, bamidronate, mTORs, and anabolic steroids also can produce FSGS. The adaptive response, adaptation to systemic disease like hypertension, diabetes, obesity, renal dysplasia or hypoplasia, renal artery stenosis, cholesterol emboli, and vascular disease can lead to FSGS. So this cartoon showed that the mechanistic classification of FSGS. It could be primary due to circulating permeability factor. As we said, it is this hypothesized factors like soluble urokinase plasminogen activator receptor, cardiotrophin like cytokine factor 1, and CD25. All of these can affect the podocyte function. Genetic factors including familial, with history of familial FSGS or apolipoprotein 1. This is a major susceptibility gene. Or secondary, these are the causes, the mechanistic causes of FSGS. This is summary. The secondary cause could be due to hyperfiltration injury, due to reduced nephron mass in low persuade patient, reflux nephropathy, renal dysplasia, and other renal diseases. Glomerular hypertension, like what happened in obesity, hypertension, sickle cell disease. Direct toxicity to or direct podocytopathy in cases of viral infection or drugs. The primary form of FSGS could be due to circulating permeability factor, which should trigger sudden and generalized food process effacement of the podocytes. And these are the molecules blamed or accused in the development of this disorder. Genetic cause of FSGS, as we said, there are more than 50 genes identified with some mutations, and this genetic form is common in pediatrics with familial disease, and usually it is sporadic and steroid-resistant, and usually diagnosed before the age of 10 years. And usually it is present with nephrotic syndrome in pediatrics, but in adults, usually it is variable, it has a variable presentation. Apolipoprotein 1 associated nephropathy, it is related to the mutation in the APOL1 variants, genes, G1 and G2 variants, has a risk of the increased risk of progression to end-stage kidney disease, especially in cases with podocyte disorders like FSGS, HIV nephropathy, lupus, sickle cell nephropathy. Regarding COVID-19 associated nephropathy, there are some trials, case series of this disorder. All of them are African American. Pathologically, FSGS, we can see by light microscopy some sclerosis of some glomeruli. This is focal, and only portion of the glomeruli, this is segmental. So the name is, so its name came as a focal segmental glomerulus, focal segmental glomerulosclerosis. So one glomerulus is needed to to make the diagnosis. Immunofluorescence could be negative, but IgM and the C3 deposits can be observed also. Electron microscope, of course, showed variable degree of podocyte food process effacement. This is Columbia classification, pathological classification based on the light microscopy. And more than one lesion could be present in the same patient. This is the hilar sclerosis. This is a glomerular tip lesion. This is a collapsing form, and this is a cellular form with foam cells development. The fifth variant is a non otherwise specified classic variant. This is the commonest form. This is the glomerular tip lesion with its good prognosis, while this is a hilar form, the perihilar form. And this is a collapsing form which has a poor prognosis, and this is a cellular form. How can we differentiate primary versus and secondary FSGS? Clinically, primary glomerulonephritis usually occur in younger patients with sudden or acute onset of edema, nephrotic range proteinuria, hypoalbuminemia, and normal creatinine, with extensive effacement of the food processes. And the glomerular size is usually normal. But in secondary form, it usually occurs in elder patient with gradual onset and mild edema, subnephrotic proteinuria, normal albumin, and usually the creatinine is a little bit high at the time of diagnosis. And usually the variants are either perihilar or collapsing with enlarged glomeruli. How can we manage FSGS? FSGS, according to the KDIGO guidelines, if there is a feature suggestive of primary form, like heavy proteinuria, hypoalbuminemia, with or without edema, so we'll consider immunosuppression plus the general measures. If no response, we consider genetic testing. In the absence of the feature suggesting of primary form, we can proceed to evaluate for the secondary causes and consider screening for genetic testing if there is feature suggestive genetic forms, and don't start immunosuppression in such cases. We can proceed with supportive measures and monitor proteinuria and serum albumin. If there is no response or progression of kidney function and worsening of proteinuria, we can consider it as primary form and proceed. The goals of treatment is to induce complete remission with less proteinuria than 300 milligram per day, stable creatinine and albumin more than 3.5 gram, or partial remission with proteinuria ranged between 0.3 to 3.5 gram per day, decrease creatinine below 50% of the baseline, and normal albumin. The treatment of FSGS consists of two important measures, conservative measures for all cases of FSGS, either primary or secondary, with RAS blockade, blood pressure control, volume control, SGLT2 inhibitors, cardiovascular risk management, and vitamin D. Immunosuppression, of course, for primary FSGS only, and genetic testing if not responding. The management of edema in FSGS started by loop diuretics, first line, once or twice until full dosage, sodium restriction below 2 grams per day, thiazide diuretics or metolazone if the GFR is less than 30, and monitor adverse effects, especially electrolyte imbalance and deterioration of kidney function. And in resistant cases, you can combine the previous measures plus ultrafiltration or hemodialysis. Management of hypertension and proteinuria in FSGS start by ACE or ARBs and as a first line and maximize it but take care of deterioration of kidney function and hyperkalemia. The target systolic pressure 120 and below, or mean pressure 50 milligram in millimeter Hg in children. The target proteinuria should be less than 1 gram. And delay the ACE, and you can delay the ACE or ARBs if there is response to the immunosuppression without hypertension. Combined with potassium wasting diuretics and the correct acidosis, of course. Lifestyle measures should be adopted in such cases, like with salt restriction, exercise, stop smoking, avoid overweight, especially in diuretic-resistant cases. Hyperlipidemia should be managed in nephrotic patients with high cardiovascular risk score. Of course, lifestyle measures, and if the score of cardiovascular risk score is high, you can start by a statin therapy or non-statin therapy. The management of hyperlipidemia is aiming to upregulate the LDL receptor, either by reduction of the synthesis of cholesterol at the MHMG-CoA reductase enzyme inhibition by the statin therapy, or by decreased absorption of cholesterol in the diet through the intestinal absorption, or through PCSK9 inhibitors, which decrease LDL receptor degradation. All of them will enhance the LDL uptake and reduce the cholesterol. Of course, the risk of infection should be minimized by pneumococcal vaccine, screening for endemic disorders like TB, syphilis, and viral infections. Consider strongyloides superinfection in cases who are planned to receive immunosuppression, heavy immunosuppression, especially rituximab and cyclophosphamide. What about the immunosuppression it is only for FSGS? The categories, the targets of management are targeting the permeability factor. This is for primary form, by removing this permeability factor through extracorporeal procedures like plasma exchange, IA, LDL apheresis, supporting suppression of the permeability factor formation by using immunosuppression, targeting hemodynamic abnormalities by RAS inhibitors, sparsentan or ACG-LT2 inhibitors, targeting the genetic mutations, promoting podocyte and promote regeneration and repair, and targeting inflammation and fibrosis. So the initial therapy for primary FSGS is steroid, 1 milligram per kg per day, or alternative dose by 2 milligram per kg every other day. The duration should be at least 4 weeks and maximum 16 weeks. Usually some improvement happen at 8 weeks. This study, there are some studies comparing the relatively long duration of treatment with 16 weeks duration of steroid versus 8 weeks. And they found that there is some improvement, there is some improved efficacy with 16 weeks versus 8 weeks, with partial remission in 30 to 40%, and complete remission up to 35%. So longer duration is associated with better outcome. Of course, this efficacy should be associated with protection. We have to consider protection of the bone, protection of the stomach, protection against infections, and of course, oral hygiene. What about the steroid-resistant FSGS? The KDIGO guidelines suggest that using CNI, especially cyclosporin, at 3 to 5 milligram per kg in 2 divided dose at least 4 to 6 months, for about 1 year, 12 months. And if there is side effects or intolerance to the cyclosporin, they suggest also to use MMF plus high-dose dexamethasone. What about the cyclosporin versus placebo? In this study, cyclosporin in this randomized control trial, including from Toronto, including 49 patients with steroid-resistant FSGS, they compared cyclosporin versus placebo, and they found the remission rate is higher, significantly higher in the cyclosporin treated patients, as you see here. What about the cyclosporin versus MMF? Through the FSGS CT study, they included in this randomized controlled trial, including 136 patients. Most of them were children with eGFR more than 40 and urine proteinuria more than 1 gram per gram BCR, and a follow-up of about 3 years. They compare cyclosporin with trough level 100 to 250 nanogram per ml versus MMF and the oral dexamethasone. And all patients received the steroids, 0.3. They found that no difference between the two arms, possibly due to the underpowered and heterogeneous population included in the study. So what should we tell our patient regarding cyclosporin as a first line of treatment? This treatment this is a long-term treatment in the doses of 3 to 5 milligram with the trough level around 150 nanogram per ml, which will continue for at least 6 months up to 1 year. And of course, the efficacy with complete remission nearly 12 to 19%, partial remission around 40-60%, and the chance of relapse is 50%. Of course, we have to explain the side effects of cyclosporin regarding the kidney function, nephrotoxicity, and hypertension. Alternate therapy, other therapy for steroid-resistant FSGS include rituximab and cytotoxic drugs. Rituximab, there are three trials. The Spanish study included 8 patients with partial response 25% and 63% have no response. The Indian study included 58 patients with steroid and CNI resistant FSGS, and with the poor response to the rituximab. In Kuwait, they included 18 children and adults with partial remission, with reported 94% partial remission, possibly because more than 50% of patients have had partial remission before rituximab therapy. Regarding cytotoxic, so the rituximab is of no benefit in most of the studies. Cytotoxic drugs also, from a study from Germany, they found from a randomized controlled trial from Germany included 57 adults with they compared cyclosporin plus steroid versus steroid and chlorambucil, and they found no added benefit of chlorambucil. The same remission rate also was reported regarding the use of cyclophosphamide. What about the sparsentan in FSGS? This is combined angiotensin 1 and endothelin TA blockade in Gheith study. This is phase 2 randomized controlled trial for 8 weeks duration, including 109 patients. And they compared sparsentan with different dosages versus irbesartan 300 milligrams. The baseline proteinuria and serum albumin were comparable between the two arms, and they found that dual blockade of AT1 and ETA receptors by sparsentan reduced proteinuria significantly compared to AT1 blockade alone. Regarding the SGLT2 inhibitors, in a subgroup analysis in DAPA-CKD study, they found that dapagliflozin reduced the rate of progression of CKD among these patients, but this was not significant. Again, this study found that the effect of SGLT2 inhibitors was better in IgA nephropathy compared to the FSGS. There are other studies ongoing now, including sparsentan, bardoxolone, voclosporin, and other agents that we hope that it will improve the outcome of such patients. Regarding recurrence of FSGS after transplantation, the TANGO project This is an observational multi-center international cohort study aimed to investigate glomerulonephritis recurrence post-transplant. They evaluated more than 11,000 kidney transplant recipients screened for FSGS, and they found 176 patients with FSGS as original kidney disease, and they found FSGS recurrence in 57 patients, and nearly 40% of them lost their graft over a median period of 5 years. This cartoon showed that a complete remission was observed in nearly 21%, while partial remission was observed in 36%, the total remission in the total patient. But in those who received plasma exchange alone, the partial and complete remission rate was nearly 70%, while addition of rituximab or treatment with rituximab alone without plasma exchange had no beneficial effect in such cases. So they also concluded that there are some risk factors for recurrence, especially older age, white race, body mass index at transplant, and native kidney nephrectomies. We can conclude from this talk that FSGS is a histological pattern of injury, not a single disease. Histological classification include disease entities like collapsing FSGS and APOL1 associated nephropathy. The current management plan is through multi-omics precision medicine approach. Thank you.